Go ahead.
So thank you, Endocrine Society of Bengal, and especially Professor Nilanjan Sengupta and Shomit Goswami for the kind invitation. Today we will have a very interesting discussion and regarding a very important topic, something more in the purview of cardiologists, that is use of antiplatelets and Noacs in diabetes, something which is very important in day-to-day practice. And we have an excellent speaker in Dr. Shubhra Chakraborty, who is going to take us through. We have different segments with regards to use of antiplatelets in CAD, in cerebrovascular disease, in peripheral arterial disease, in primary prevention, in secondary prevention, as well as in patients who have atrial fibrillation, and also in acute scenarios like ACS or stroke as well. So hope he can cover some aspects of all of these, or at least major part of this. Looking forward to a very interesting lecture. Over to you, Dr. Shubhra Chakraborty.
Thank you, everyone. Can I share my slide? One second. Yes, one second. Visible? Hello? Hello? Is my slide visible?
No, not
Hello?
yet. You, Shubhra, you click on your slide.
Yeah. Is it visible, sir?
No, not yet.
Sharing.
You can reshare once.
Okay, stop share. Okay, I'm trying, sir.
You'd stop share. Yeah, don't
increase that. Intraplatelet cyclic AMP basically inhibits P2Y2 signal pathway in platelet, and there is reduction in platelet activity. This happens when the insulin function is intact and there is no insulin resistance. But in case of type 2 DM, the insulin resistance is there, the platelets have decreased sensitivity to insulin, and that causes the lower cyclic AMP level. So there is reduced P2Y2 inhibition, and there is increased platelet reactivity. This is one of the features of diabetic platelet. So if we go to the mechanistic view of coagulation cascade, we can see there is, in diabetes, there is higher amount of tissue factor, thrombin or factor 2 and fibrinogen production. There is lower amount of protein C and antithrombin complex that favors thrombin generation and fibrin mesh formation. There is higher amount of PI1, the plasminogen activator inhibitor 1, and TAFI, the thrombin activator fibrinolysis inhibitor, that ultimately inhibit the activation of plasminogen to plasmin, which hinders the fibrinolysis. Diabetic thrombi has compact fibrin network and densely packed thin fibrin fibers that is resistant to fibrinolysis. So this is the triad of atherothrombosis in diabetes, the altered activity of coagulation factor, increased platelet reactivity, prothrombotic environment. So we have primary prevention, single antiplatelet, secondary prevention, dual antiplatelet, and antiplatelet and anticoagulant known as DAPI. We will see what is happening. This I have already discussed: diabetes with platelet dysfunction, abnormal coagulation factors, suboptimal platelet inhibition, endothelial dysfunction, and oxidative stress. So about the antiplatelet drugs, we all know the cycloxygen inhibitor, aspirin, adenosine receptor inhibitor, P2Y2 inhibitor, irreversible inhibitors are clopidogrel, ticlopidine, and prasugrel. Ticlopidine is out of the market. Prasugrel is the irreversible inhibitor, and reversible inhibitor, ticagrelor and cangrelor. Phosphodiesterase inhibitor, 3 inhibitors, silostazol, is nowadays not commonly used. And these are the GP2B3 inhibitors used during PCI. Newer antiplatelet thrombin receptor antagonists, Vorapaxar and Atopaxar, failed in trial, and others are not in clinical use till date. So, about the pharmacointroduction of antiplatelets, we can see aspirin causes inhibition of cycloxy enzyme irreversibly. Clopidogrel and prasugrel are thenoparidine that are pro-drug that irreversibly bind to P2Y12 inhibitors. Ticagrelor is a reversible binder of P2Y12, and cangrelor also reversibly bind to P2Y12. Amongst these, cangrelor is given IV and has short half-life, and ticagrelor has half-life of time to peak action is 30 minutes, and prasugrel is 30 minutes, and ticagrelor is 1.5 hours. I'll skip the mechanism of action of aspirin, but the one important point is the small dose of aspirin inhibits thromboxane A2 synthesis in platelets, but not the prostacyclin synthesis in endothelium. So low dose of aspirin spares the endothelial synthesis of PGI2, and there is thus better antiplatelet activity. I will rapidly touch upon the concept of antiplatelet resistance. In broad sense, the antiplatelet resistance refers to continued occurrence of ischemic event despite adequate antiplatelet therapy and compliance. The resistance should be restricted where aspirin and clopidogrel fails to achieve their pharmacological effect at cellular level. From clinical point of view, it should be termed as either ineffectiveness, failure of therapy, or more adequately, variability in responsiveness. In different meta-analysis, the aspirin resistance prevalence around 0 to 57% with mean of 24%. There are multiple mechanisms proposed to contribute increased intraplatelet reactivity. We have already discussed hyperglycemia, insulin resistance, and associated metabolic conditions. So about the clopidogrel resistance, there are multiple factors that lead to reduced clopidogrel bioavailability. One of the important things is interaction with P450 or type 3A4 system and involvement of PPI like omeprazole, and baseline individual variability is there in patients with diabetic or insulin resistance. There is a lot of genetic variation, clopidogrel resistance, genetic polymorphism is there, and there is accelerated platelet turnover in diabetes that leads to clopidogrel resistance. So clopidogrel has some resistance pattern, and we have not seen any ticagrelor resistance pattern. But let me tell you, the measurement of antiplatelet resistance is a cumbersome effect, but we do not measure antiplatelet resistance regularly. So coming back to our topic, the aspirin. Aspirin in primary prevention. Aspirin is the drug that is heavily investigated in primary prevention research and which showed significant benefit in primary prevention of vascular events. The results of primary prevention are driven by decreased occurrence of non-fatal MI. All aspirin trials showed increased bleeding compared to placebo, regardless of presence or absence of diabetes mellitus. These bleedings are mainly extracranial, like GI bleed. In JPAD trial in Japanese patients, the low dose aspirin did not diminish the risk of ischemic events, so it's a negative trial, but increased GI bleed, but it's a small underpowered study. In 2018, 3 large trials described aspirin primary prevention. The trials are ASPRE, ASCEND, and ARRIVE. In ARRIVE trial, the diabetes mellitus patients are excluded, and ASPRE trials, 19,000 patients are examined, of which 11% are diabetic, where aspirin is given 100 milligram daily compared to placebo for 56 months. The ischemic endpoints are comparable with placebo. But coming to ASCEND trial, where 100% patients are diabetic, we have used 100 milligram aspirin daily in person who had diabetes without manifest cardiovascular disease. And ASCEND trial follow-up is for 7.4 years. The primary efficacy endpoints are non-fatal MI, non-fatal stroke, TIA, death from any vascular cause. Primary safety endpoints is in any confirmed intracranial hemorrhage, sight-threatening bleeding in eye, gastrointestinal bleeding. So in ASCEND trial, it has been seen that compared to placebo, aspirin decreases the first serious vascular event over a period of 7.4 years. And this benefit is notable. Results. At 7.4 years follow-up, major vascular events occurs 8.5% in aspirin group versus 9.6% placebo group. P-value is highly significant, albeit there is 29% increase in major bleeding in aspirin group, mainly GI bleeding. The ASCENT trial result could be visualized in some other way. Because of the benefit, it has been dived into the ASCENT trial, and it has been seen in ASCENT data we have used more introduction of high sensitivity troponin. The definition of MI includes minor ischemic event, so aspirin efficacy may be slightly overestimated. And in this era, we have used heavily statins and antihypertensives that can also have some anti-ischemic effect. So aspirin efficacy may be slightly overestimated. But about the bleeding, unfortunately, the PPI use is only in 1/4 group of ASCENT patients, that too almost at the end of the study period. No wonder GI bleeding will occur. So coming to the primary prevention, ACC/AHA guideline, primary prevention of cardiovascular disease, they have told to use aspirin in class 2B indication. Low dose aspirin might be considered for primary prevention of ASCVD events among selected adults 40 to 70 years of age who are at higher ASCVD risks but not at increased bleeding risk. They have not mentioned about diabetes. But coming to ESC primary prevention guideline of cardiovascular disease 2021, ESC has clearly mentioned in patient with diabetes mellitus at high or very high severity, low dose aspirin may be considered for primary prevention in absence of clear contraindications. It is a class 2B indication. So antiplatelets in secondary prevention, aspirin is recommended as class 1 low dose. Clopidogrel is recommended as alternative to aspirin in secondary prevention in case of aspirin intolerance. Class 2B, clopidogrel may be considered in preference to aspirin in patients with established ASCVD. Coming to secondary prevention, in contrast to primary prevention, the antithrombotic efficacy for secondary prevention is well established, especially in patients with diabetes mellitus. Aspirin represents the mainstay of treatment in antiplatelet pharmacotherapy with cardiovascular disease due to its well-documented role in secondary prevention as well as widespread availability and affordability. This is SFPT strategy. Following ACS, we use DAPT, aspirin plus clopidogrel or ticagrelor. The recent trial Adaptable showed there is no advantage of using 325 milligram aspirin as secondary prevention in preference to 100 milligram or 81 milligram. So this trial answered that low dose aspirin in secondary prevention is fairly good. We cannot use Europe 100 milligram, US 81 milligram, and somewhere 150 milligram or 325 milligram. So Adaptable trial fairly answered that low dose aspirin is fairly good with respect to the dosing. So what are the randomized clinical trials in different antithrombotic strategies in patients with diabetes? There are plethora of trials. In stable CAD, DAPT and dual pathway inhibition, if we consider, there are two important trials. One is THEMIS, that is in stable CAD, and one is Pegasus TIMI 54, that is in presence of previous MI, and COMPASS is dual pathway inhibition in stable atherosclerotic cardiovascular disease. For DAPT, this Triton TIMI 38, Plateau, and ISA-REACT 5. Plateau trial is comparing ticagrelor with clopidogrel, and this Triton TIMI 38 prasugrel with clopidogrel. And about post-intervention, if we look at the P2Y2 inhibitor monotherapy, there are three trials: Global Leaders, Smart Choice, and Stop DAPT2. They are basically investigating short DAPT use in presence of high bleeding risk, and Twilight Trial also using ticagrelor in shortened DAPT duration. If we see the P2Y2 inhibitor monotherapy in diabetes as secondary prevention, in randomized the CAP3 trial, we included 3866 patients with diabetes mellitus, aspirin compared with clopidogrel for a recent ischemic event, that is MI or stroke. Among the patients of diabetes, clopidogrel use resulted in 21% risk reduction of primary endpoint, and most importantly, 37% relative risk reduction in rehospitalization for bleeding events as compared to aspirin. And if we see the P2Y2 inhibitor therapy on background of aspirin, the CURE trial is clopidogrel plus aspirin versus aspirin in acute coronary syndrome. Triton TIMI 38, it is after PCI in ACS patients, head-to-head trial between prasugrel versus clopidogrel, where prasugrel is the winner. In plateau trial, in ACS subset, ticagrelor versus clopidogrel on top of aspirin, where ticagrelor is the winner. And recent ISA React 5 that showed the ACS patient undergoing invasive treatment, superiority of ticagrelor is challenged. Ticagrelor versus prasugrel, it has been seen the primary endpoint of composite of death, MI, and stroke at 1 year occurred in 9.3% of patients ticagrelor and 6.9% those on prasugrel. In this ISA React 5, superiority of ticagrelor is challenged by prasugrel. So these are the trials we are talking about: Kyoto, Tritantimi 38 and Plateau. Now these are two trials we are going to talk about: Pegasus Timi 54 and Themis trial. Very important trial is Pegasus Timi 54. It is basically a prolonged DAPT trial in patients of previous MI. This is very important. In patients with previous MI, 2 doses of ticagrelor, either 90 mg twice daily or 60 mg twice daily, are tested on the top of aspirin for prolonged duration of 33 months. In Pegasus Timi 54 cohort, 32% patients are diabetic. It has been seen in diabetic, recurrent ischemic events are reduced in diabetic patients irrespective of the dose of ticagrelor. Either 90 mg or 60 mg ticagrelor reduce the recurrent ischemic events in the prolonged duration. There is higher absolute risk reduction in diabetic patients with ticagrelor 60 mg twice daily dose compared to placebo. But very important is bleeding risk is increased irrespective of diabetes or non-DM status. So bleeding is always higher while you use the prolonged DAPT. Now coming to Themis trial, the subset of Themis trial is they have chosen stable coronary artery disease and in diabetes. 19,000 patients and who have stable coronary artery disease and type 2 DM. Patients received either ticagrelor plus aspirin or placebo plus aspirin. The median follow-up is also prolonged around 39.9 months. So if we see Themis trial in diabetic, 100% patients are diabetic. This is prolonged DAPT trial in stable CAD. This is a well-powered study. 19,000 patients are tested with established CAD. There is without prior CV events. There is a difference between Pegasus Timi 54. It has history of MI in Pegasus Timi 54 and it is established CAD without prior CV events. Already on aspirin and the follow-up is 39.9 months. They have tested ticagrelor plus aspirin versus placebo plus aspirin. Major adverse cardiac event or ischemic endpoints are decreased in ticagrelor group versus aspirin group, but the Timi major bleeding is increased 2.3-fold in ticagrelor group at 39 months, 1.7-fold increase in the intracranial bleeding. Number needed to treat by number needed to harm is 1.5, suggesting more harm in ticagrelor use for prolonged duration. Hence, routine DAPT use with aspirin plus ticagrelor in stable CAD is not recommended. Routinely we cannot use. But if we see the Themis PCI subgroup analysis, that means though an increased bleeding observed in all ticagrelor arm, but the net clinical benefit is favoring ticagrelor in patients who has undergone PCI, but not in those without a history of PCI. So, based on the results of Pegasus Timi 54 and Themis trial, it is suggested that the patient of diabetes mellitus with either a history of prior MI or prior PCI may benefit from ticagrelor 60 mg dose twice daily on the top of aspirin. So these were the short DAPT trials, global leaders, smart choice and stop DAPT 2. They have tried to examine the shortened duration of DAPT carries equivalent ischemic risk and less bleeding risk or not. We will discuss the Twilight trial where ticagrelor monotherapy lowers bleeding without risking ischemic events. It's a double-blind trial which examines the effect of ticagrelor alone as compared with ticagrelor plus aspirin with regard to clinically relevant bleeding among patients who were at high risk for bleeding or an ischemic event and undergone PCI. 9,000 patients are enrolled and 7,000 patients underwent randomization after 3 months. So Twilight trial is basically a shortened DAPT with ticagrelor. It's a double-blind clinical trial randomized to high-risk patients after PCI. After 3 months of DAPT of ticagrelor and aspirin, they have randomized to either ticagrelor monotherapy or ticagrelor plus aspirin. What is the result? Ticagrelor monotherapy harm showed similar ischemic events but lower incidence of bleeding at 1 year of follow-up. So, ticagrelor monotherapy arm has lower incidence of bleeding than ticagrelor plus aspirin at 1 year. So dropping aspirin is going to be an option even before 1 year of post-PCI cases with high risk for bleeding. Twilight conclusion: among high-risk patients who underwent PCI, Twilight is high-risk patient who underwent PCI and completed 3 months of dual antiplatelet therapy comprising of ticagrelor and aspirin. After that, ticagrelor monotherapy was associated with lower incidence of clinical relevant bleeding than ticagrelor plus aspirin with no higher risk of death, MI or stroke. Coming to Twilight diabetes sub-study, 37% of Twilight cohort were analyzed in this sub-study. That is 37% of Twilight patients are diabetic. Major bleeding is lower in ticagrelor monotherapy versus dual therapy. Ticagrelor monotherapy has similar rate of ischemic events as ticagrelor plus aspirin dual therapy. Ischemic events is similar in ticagrelor monotherapy versus ticagrelor plus aspirin dual therapy. The statistics says if we consider bleeding and ischemia as single composite endpoint, there is a 39% decrease in the net adverse clinical events among diabetic patients receiving ticagrelor monotherapy. P-value is highly significant. So the significant interaction between diabetes mellitus status and treatment group for this composite endpoint was noted. Conclusion: diabetic patients may derive larger benefits from ticagrelor monotherapy relative to non-diabetic patients in Twilight cohort of high-risk patients. Coming to diabetes prevalence in AF cohorts. In Noacs RCTs, we have seen 23 to 40% patients are diabetic. In Garyfield AF and Orbit races, 22 to 29 patients are diabetic. And European Heart Rhythm Association administrative claims database, 1 in 3 patients of AF are diabetic. Diabetes has multiple complications like diabetic retinopathy, kidney disease, neuropathy, peripheral arterial disease, and stroke is already increased 2 to 4-fold in severe mortality and stroke. Cardiovascular disease already increased in diabetic. In AF, 7 out of 10 patients die in CV causes. Higher likelihood of CV death with diabetes. We all know the limitations of warfarin therapy in AF. I'm not going to repeat it. Unpredictable response of VK, narrow therapeutic window, continuous taking of INR, drug-to-drug interaction, food interaction that is pushing back warfarin in non-valvular AF. So this is the coagulation pathway where we have Noacs like rivaroxaban, apixaban, edoxaban, which inhibit the factor 10A, and dabigatran inhibit the thrombin or factor 2A. So these are the two group of Noacs we use in atrial fibrillation. Advantage of new anticoagulants are basically rapid onset of action, predictable anticoagulant effect, and low potential for food interactions, low potential for drug interaction. No routine coagulation monitoring is required like P-time INR in case of VKA. The worst thing about AF is not AF but ischemic stroke. Non-valvular AF increases the stroke risk by 5-fold. Stroke assessment is done with CHAD-S2 or CHAD-A2-DS2-VASC scoring. If we see this CHAD-A2-DS2-VASC criteria, where D stands for diabetic, giving a score of 1, age 75 years, giving a score of 2, hypertension, giving a score of 1, any heart failure or LV dysfunction, giving a score of 1, stroke or TIA or thromboembolism, giving stroke of 2, vascular disease, score of 1, age 65 to 74 years, score of 1, any sex category, female gender, is score of 1. So females are already at score 1. It has been seen that the score gradually increases and the adjusted stroke risk also increases. So the guideline says if the score of CHAD CHA2 DS2 VASC score is 0, there is no need of antiplatelet or anticoagulant. If the score is 1, OSC might be considered except females, because females are always score 1. And if the score is more than equal to 2, oral anticoagulation therapy has to be given, where Noac and VK in non-valvular AF are class 1. If the patient has mechanical heart valves or moderate to severe mitral stenosis, the Noacs are contraindicated. We have to use VK. So, what are the use of Noacs in AF substrate? What are the contraindication? Mechanical prosthetic valve, we cannot use Noac. Moderate to severe mitral stenosis, usually rheumatic angina, we cannot use Noac. But other group of cardiovascular diseases are included in Noac trial, like mild to moderate native valvular disease, like mild to moderate aortic stenosis or regurgitation, degenerative mitral regurgitation, severe aortic stenosis. Bioprosthetic valve after 3 months are eligible for Noac, except in rheumatic mitral stenosis. Mitral valve repair after 3 months is eligible in Noac. Hypertrophic cardiomyopathy eligible for Noac, with, of course, atrial fibrillation. TAVI also may be eligible for Noac. So these are the Noac dosing in approved indication. I will go through the slides very fast. For stroke prevention in atrial fibrillation, dabigatran dose is 150 mg twice daily. Apixaban is 5 mg twice daily. Rivaroxaban is 20 mg once daily as per the creatinine clearance. Edoxaban is 60 mg once daily. The treatment of DVT dose is bit different. We have to remember this. In rivaroxaban, it is for treatment of DVT or pulmonary embolism, it is 15 mg twice daily with food for first 21 days and followed by 20 mg per day. In apixaban, 10 mg twice daily for 7 days, followed by 5 mg twice daily. Dabigatran is 150 mg twice daily, following 5 to 10 days of initial parenteral anticoagulant. So these are the different for prevention of DVT or pulmonary embolism. The similar dose is used. And now coming to Noac versus warfarin in non-valvular AF scenario, 4 randomized trial has investigated Noac versus warfarin in non-valvular AF scenario. Rocket AF trial investigated rivaroxaban, Aristotle trial investigated apixaban, and Relay trial investigated dabigatran, and Engage AF trial investigated edoxaban. In all of this trial, one common thing is seen. The CV date, stroke, and major billing are almost same with warfarin as well as in Noac. But the ICH, the occurrence of ICH, the shift to the left, it favors Noac. The ICH is less, definitely less in Noac as compared to warfarin. So Noac is emerging as class 1 indication in non-valvular AF due to these trials. Now coming to this pharmacokinetic of Noacs, there are some points I want to make about the bioavailability. Rivaroxaban has to be given with food because the bioavailability increases with food. About the renal clearance, this is very important. The renal clearance of Noac, the apixaban has least renal clearance is 27%, and highest renal clearance is for dabigatran. So dabigatran cannot be used in diabetic CKD state or used in moderate dose reduction. Apixaban may be used, and edoxaban and rivaroxaban is between middling of the renal clearance. And one important feature of dabigatran is dyspepsia that many patient complaints, and patient may discontinue the drug due to dyspepsia. We have to give the patient with PPI cover. So these are the point I want to make. So Noac dose modification CKD, diabetes has common CKD pattern, so we have to know. What I can see in this, this is from European guideline, below 15 milli per minute, the end stage renal disease, no Noac is recommended. However, US guideline recommends apixaban 2.5 mg twice daily. Between 15 to 30 milli per minute, rivaroxaban 15 mg may be given, edoxaban 30 mg, and apixaban can be given 2.5 mg twice daily. And we can see below 50 ml per minute, the dabigatran dose should be reduced to 110 mg twice daily, and rivaroxaban dose should be reduced to 15 mg from 20 mg, and apixaban from 30 to 90, the dose can be remain unchanged to 5 mg twice daily or 2.5 mg twice daily. So apixaban is safer in renal failure. So I'll skip this. What to use, which Noac, I think we all know. If there is a previous CAD or MI, we use rivaroxaban. If there's renal impairment, we use apixaban or rivaroxaban. Rivaroxaban is reduced doses. In GI upset, we cannot use dabigatran. We have to use apixaban or rivaroxaban. And if the patient is wants the once daily formulation, there is rivaroxaban only we have. In patient with previous GI bleed or high risk patient, apixaban. Elderly patient, always apixaban. But if the patient has high risk of ischemic stroke with low bleeding risk, dabigatran 150 milligram twice daily is superior. We have to consider Hasbled score before using any NOAC or any treatment. So coming to NOAC in AFPCI scenario, what are the evidence of NOAC in AFPCI? The 4 trials, Pioneer AF, PCI, Redual PCI, Augustus ACS, and Infrast AF PCI, examine rivaroxaban, dabigatran, and apixaban and eroxaban as compared with warfarin as triple therapy or dual therapy after ACS, and the results are like this. They have made some group in Pioneer AF, rivaroxaban with P2Y2 inhibitor versus rivaroxaban with VK. These groups are made and they have basically seen whether triple therapy and dual therapy, which is favorable. So we'll come back to it, and we can see that the new guidelines what we have, AF with need of PCI. If we see AF with need of PCI, what the guideline says, this is a summary slide. ACS patient with AF and indication of oral anticoagulation, if there is ischemic risk is prevailing, the triple therapy, NOAC with aspirin and clopidogrel up to 1 to 6 months can be given. After that, dual therapy with NOAC and clopidogrel. The dual therapy basically consists of NOAC and clopidogrel. Clopidogrel is used with NOAC. Aspirin is less used with NOAC. And the triple therapy duration is shortened where there is a risk of bleeding. It can be shortened to 1 month to 7 days. And after that, dual therapy of NOAC with clopidogrel is recommended up to 12 months. And in case of medically managed ACS, dual therapy of NOAC with clopidogrel is recommended. And after 12 months, it is always NOAC monotherapy. So these are the guidelines we have with 2020 ACC expert consensus and as well as European Heart Rhythm Association. The basic of this guideline is same. Minimize the triple therapy, warfarin, the NOAC, aspirin, clopidogrel. This combination to be minimized for 7 days to 1 month. If we can use dual therapy, we have to use clopidogrel in preference to ticagrelor or prasugrel because there will be high bleeding risk with ticagrelor or prasugrel. So for dual therapy, clopidogrel and NOAC are recommended, and for after 12 months, in any case, AF with PCI, we only use NOAC indefinitely. So basis of this concept come from ACS with PCI. If in a patient of index patient of ACS, if we look the acute phase, the acute phase there is platelet mediated risk as well as the thrombin mediated risk. The focus within first 3 months is on antiplatelet therapy, and in between 3 months to 12 months there is stable phase. The thrombin mediated risk is also there, and platelet mediated risk is gradually coming down. So we can try short DAPT therapy in between this window period. But when it is above 12 months, it basically enters a chronic phase where stent independent risk factors are there, like like clinical and genetic risk factor scores, biomarkers like HSCRP, D-dimer, etc. So chronic level of platelet activation, thrombin formation depend on concomitant risk factor. So after this, basically the platelet risk is minimal and thrombin risk is similar. And initial phase, the platelet risk is higher, and middling phase platelet risk gradually fall down to the thrombin mediated risk. So coming to the crosstalk between platelet and coagulation, we can see in any case of vascular injury, there will be liberation of tissue factor, which activate factor 10A, and that activate factor thrombin, and thrombin changes fibrinogen to fibrin, and the thrombin also activate the thrombin receptor on platelet that creates the platelet hyperreactivity. So we have basically few pathways to inhibit over here. One is the age-old aspirin pathway, cyclooxygen inhibition. Second is clopidogrel, prasugrel, and ticagrelor, the P2Y12 inhibition, the ADP-mediated platelet aggregation inhibitor. Third, that is the thrombin receptor inhibition, vorapaxar. Fourth, the factor 10A inhibitors like apixaban, rivaroxaban, and fifth is dabigatran, that is thrombin inhibitor. So these are the canonical concept of atherothrombosis. Now, if we come to the concept of dual pathway inhibition, where the COMPASS trial is the base, there are some non-canonical pathway of atherothrombosis. It has been seen in spite of aspirin and clopidogrel, in spite of this cyclooxygen inhibition or the P2Y12 inhibition, there is atherothrombosis, there is stent thrombosis. So the investigation dig into how it is occurring. So for this, we have to see two alternative pathways. Aspirin, apart from the cyclooxygen inhibition, it also increases the clot porosity or permeability by acidizating the lysine residue of the fibrin. So this is another mechanism of aspirin that increases the fibrinolysis. And how the factor 10A acts. This factor 10 is pivotal in this function. It has been seen the factor 10A activates thrombin, and thrombin acts through the PAR1 receptor, protease activated receptor 1 receptor signaling. And factor 10 itself can activate PAR2 receptor on platelet and activate the platelet. So this factor 10A can cause indirect activation of platelet through thrombin through PAR1 receptor, or can direct activation of platelet through PAR2 signaling. So in that way, platelet is activated and WBC is recruited, and the vascular effects of inflammation, plaque progression, and fibrosis goes. And now, if we can inhibit the factor 10 with rivaroxaban, and rivaroxaban has another effect of inhibiting leukocyte migration, and aspirin with the clot porosity, so they can synergistically act to prevent the atherothrombosis. This is called DAPI, or dual pathway inhibition. This is the basis of COMPASS trial. But before the COMPASS trial, the investigator tried some other things. Dual pathway inhibition, the story may not be fairy tale in case of ACS patient on the top of DAPT. There are some failed trial in DAPI2. It has been seen in the APRISE-2 trial, the apixaban in ACS patient with antiplatelet failed in high risk patient. There is increased major bleeding ICH that stopped the trial in 2011. This is our DAPI trial in the ACS background. Atlas TIMI ACS2 TIMI 51. Rivaroxaban tried in recent ACS patient on the top of the aspirin and clopidogrel, that increased major bleeding regardless of diabetes mellitus status. Number needed to treat by number needed to harm is 2.8. This is a negative trial in 2012. But the investigator didn't stop. The story changes in case of chronic coronary syndrome. There comes the COMPASS trial in 2017 by Professor John Eichelbaum. COMPASS trial strategy design, basically they have selected stable coid or stable pad, and the three randomized arms, rivaroxaban 2.5 mg twice daily with aspirin, or rivaroxaban 5 mg twice daily, or aspirin 100 mg twice daily. The primary outcome is CV death, stroke, or myocardial infarction. In inclusion criteria is very important in COMPASS trial. Coronary or peripheral artery disease established. CAD must also meet at least one of the following: age more than 65 years, or age less than 65 years, documented atherosclerosis or revascularization involving at least two vascular bases, that is polyvascular, or at least two additional risk factors like smoking, diabetes, EGFR less than 60, heart failure, non-lacunar ischemic stroke more than 1 month earlier. Exclusion criteria: patient high bleeding risk, need for DAPT, acute stroke, or severe heart failure, or EGFR less than 15. So basically, COMPASS trial is high ischemic risk, coronary artery disease, MI, multivessel coronary artery disease, multivessel particles, coronary intubation, multivessel CABG, and also PCI of iliac region, previous aortofemoral bypass, the peripheral arterial disease also high risk. So this is the COMPASS trial design, of which the 24 patients with CAD and with 38% had diabetes mellitus. Lot of peripheral arterial disease patients. The primary outcome of COMPASS trial we have seen rivaroxaban by aspirin versus aspirin alone. Rivaroxaban 2.5 mg twice daily plus aspirin versus aspirin alone. It reduces a 24% relative reduction of CV death, stroke, or MI with respect to aspirin alone. So the risk of major adverse cardiac events was significantly lower with rivaroxaban arm, rivaroxaban plus aspirin arm than with aspirin alone. About other endpoints, COMPASS also decreased the stroke, 42% relative reduction of stroke, 22% relative reduction of CV death, and 24% overall relative reduction of primary endpoint. For secondary outcomes, CAT death, MI, acute limb ischemia is reduced in COMPASS trial with p-value highly significant. CV death, mortality, both secondary outcomes are reduced in COMPASS trial with high significance. If we can compare benefit of COMPASS regimen in the context of routine therapies, we can see the COMPASS trial stand apart with rivaroxaban and aspirin, reducing MACE 24%, reducing CV death 18% and stroke 42%, where other therapies also decreases the MACE, CV death and stroke, but not with the same percentage as COMPASS trial. Coming to the bleeding, well, bleeding is increased in COMPASS trial, but there is no increase in fatal ICH or bleeding in critical region. It has been seen major bleeding is increased in rivaroxaban plus aspirin arm as compared to aspirin. P-value is significant, but fatal bleeding is not increased as compared to aspirin. Non-fatal ICH is increased, but not the fatal critical region bleeding. So Eugen Bronwell conclude long-term dual pathway inhibition (DAPI) with combination of rivaroxaban and aspirin reduces MACE and saves lives in chronic coronary syndrome. Patient at highest risk derive greatest absolute benefit ratio. Dual pathway inhibition therapy now a standard of care. That means antiplatelet plus anticoagulant, and now approved in more than 100 countries and worldwide. After the COMPASS trial, ESC 2019 CCH guideline came out. Rivaroxaban 2.5 mg twice daily is recommended in case of post-MI, more than 1 year, or multivessel CAD with low dose of aspirin. This rivaroxaban to be used with caution for eGFR 15 to 29 ml per minute. Also, post-MI who tolerated DAPT for more than 1 year, ticagrelor 60 mg twice daily is recommended. So rivaroxaban came into the recommendation in post-MI more than 1 year or multivessel CAD with low dose aspirin. Now coming to peripheral arterial disease, I will touch upon the peripheral arterial disease. Asymptomatic peripheral arterial disease, no antiplatelet. If there is symptomatic PAD, aspirin or clopidogrel, and clopidogrel is better in Capri subgroup analysis or multiple meta-analysis. No role of DAPT in symptomatic PAD without any intervention. Euclid trial has examined ticagrelor versus clopidogrel in symptomatic peripheral arterial disease, which include 40% diabetes patients in follow-up of 30 months, regardless of diabetes mellitus status. The ticagrelor is not superior to clopidogrel in case of symptomatic peripheral arterial disease. There is no difference in MACE or bleeding. In COMPASS peripheral arterial disease subgroup, 7470 patients, of which 44% are diabetic. Rivaroxaban plus aspirin group reduced major acute limb ischemia and major adverse cardiac event and major lower limb amputation incident regardless of diabetes mellitus status. So COMPASS PAD subgroup, the benefit remains regardless of diabetes mellitus status. This is the ESC 2021 guideline for peripheral arterial disease of using antiplatelet. If it is a chronic disease, symptomatic or asymptomatic, chronic disease symptomatic, lower extremity arterial disease, rivaroxaban by aspirin is recommended, or in asymptomatic patient, there is no indication of any therapy. In polyvascular disease, including peripheral vascular disease, the aortoiliac and femoral, rivaroxaban and aspirin is recommended as per the COMPASS trial. And for carotid stenosis or subclavian stenosis or aortic stenosis, either aspirin or clopidogrel is recommended for symptomatic disease. For asymptomatic disease, either aspirin, clopidogrel, or without any therapy, a patient has to be kept. In case of post-revascularization of peripheral arterial disease, either surgery or endovascular therapy, if we do endovascular therapy for 1 to 3 months, DAPT is recommended, aspirin plus clopidogrel. And the late trial is the lower extremity arterial disease has shown after endovascular therapy we can use rivaroxaban plus aspirin as per Voyager PAD trial. Evidence of dual pathway inhibition in peripheral arterial disease comes from Voyager PAD trial, which includes 40% of diabetes mellitus patients, 9,000 patients, of which 40% of diabetes patients is a double-blind RCT that included symptomatic peripheral arterial disease who has undergone lower limb revascularization, either surgical or endovascular, within last 10 days of prior to randomization, but a very recent intervention within 10 days of randomization. Two group, rivaroxaban 2.5 mg twice daily with aspirin versus placebo plus aspirin. The primary endpoint was acute limb ischemia, amputation, MI, stroke, CV. It has been seen in Voyager PAD trial that combination therapy of rivaroxaban plus aspirin reduce the composite endpoint. The number of acute limb ischemia is lower in rivaroxaban arm. So, post lower limb revascularization, rivaroxaban 2.5 mg twice daily with aspirin can be adjunctive therapy to reduce first limb ischemia and subsequent adverse outcome. That is why they have given rivaroxaban plus aspirin in this group. So summary, antithrombotic therapy in diabetes mellitus. If the patient has no CVD, that is primary prevention, low dose of aspirin in selected patients who are at risk for higher ischemic event but not for higher bleeding risk. The dose is 75 to 100 milligram. In case of ACS, DAPT with aspirin and P2Y2 inhibitor. Choice is either prasugrel if managed with PCI. Prasugrel has to be used when the patient is managed with PCI, or ticagrelor if managed invasively or non-invasively for initial 12 months or 3 to 6 months in case of high risk of bleeding. In case of elective PCI, DAPT with aspirin clopidogrel for 6 months or 1 to 3 months in case of high risk of bleeding, followed by single antiplatelet therapy. In chronic coronary syndrome, low dose of aspirin to be continued for lifelong. DAPT or DPI should be considered in selected patients who are at high risk of ischemic event but not at high risk of bleeding. So this is my summary slide and conclude. Thank you. Thank you, everyone.
Thank you, sir.
Thank you.
So, thank you for an excellent talk on this very complex topic with multiple difficult scenarios. There is one important question from Dr. Shomi Goswami that does clopidogrel have a role in primary prevention? Because we see a lot of patients who have been prescribed clopidogrel in primary prevention in type 2 diabetes. And I would like to add, if you could, qualify the high-risk patients for primary prevention.
Sir,
so first is clopidogrel role in primary prevention.
Clopidogrel is widely prescribed in primary prevention, but there is no guideline about clopidogrel. Only in case of aspirin intolerant patient you can use clopidogrel. That is in the from secondary prevention guideline. We cannot directly use clopidogrel. We do not have study for clopidogrel in primary prevention. And about the high risk patients, those who are high risk for atherosclerotic cardiovascular risk, we have to see the scores. There is family history of premature cat. There is enhanced atherosclerosis risk factors, dyslipidemia. These group of patients are high risk cardiovascular patients. Of course, diabetes mellitus, poorly controlled, more than 10 years. duration, they are the high risk of diabetes associated with cardiovascular patient. For this, we have to go for the scoring of pooled cohort, and we have to see which is high risk and which is intermediate risk and which is low risk.
One area probably which we want to, because you have covered peripheral arterial disease, both asymptomatic as well as symptomatic very well, including scenario for secondary prevention with patients undergoing PCI and post PCI as well. You know, one very important point of information is especially post PCI who did not have MI or who did not have significant other comorbidities. Only ticagrelor can be used in a subset of patients, who have a high bleeding risk, and that really doesn't increase the bleeding risk but provide better outcomes. So that's a very important take, because generally using ticagrelor something is we have not been very comfortable, or we have not seen very commonly in our practice. Probably cost is also an important factor.
Yes.
Regarding stroke, apart from atrial fibrillation, again, Noac very well covered with regards to Noac. Probably rivaroxaban remains the best option in probably most of the scenarios, other than very high risk patients where we may consider other alternatives. And with regards to secondary prevention of stroke, what one is, patients nowadays undergo thrombolysis for stroke, or some do not go thrombolysis for stroke. So do you have any recommendation? Do you have any recommendations, especially with patients who have thrombolized for stroke or non-thrombolized for stroke? So is it clopidogrel preferred after the initial aspirin in patients who are thrombolized?
So I'm not sure, but I think neurologists will better answer this. But I think for this purpose, I think clopidogrel is better suitable in preference to aspirin.
Yes, that's what it is, and especially in patients who are non-thrombolized, also one can use acutely in ischemic stroke DAPT as well for a short period of three to 4 weeks as well. And there is also one question coming up in the chat box, that in type 2 diabetes patients with ischemic heart disease or peripheral arterial disease and one more risk factor, as in the COMPASS trial, should we use rivaroxaban with aspirin routinely?
There is no routine use. You have to select the patient as per the COMPASS trial criteria #1, and this is with risk factor, that is okay, but you have to check the bleeding risk. You have to take the proper history, whether there is a history of GI bleed or not. If the bleeding risk is high, Hasbullet score is high, you should be better avoid using rivaroxaban, because in COMPASS trial subset there is benefit, but at the cost of bleeding. The bleeding is there. If the patient is bled after you have prescribed a new drug, costly drug, and the patient will come back to you, then what do you answer? Even if it is not a major bleeding, but if it is a minor GI bleed, the patient will do panicky and it will be very difficult to manage. So I would suggest you have to use rivaroxaban in very limited scenario, where you get the total information, patient bleeding risk and atherosclerotic risk.
So again, especially we have seen this DAPI therapy coming up even for patients. One is the PAD has been highlighted, very selective selection, and especially also in patients with CAD, long term. I'm saying, especially long term therapy with rivaroxaban and aspirin. Only also there also we have to be very careful, probably because of again the high bleeding risk. Your take on that?
Yes. That is for sure, sir. Any long-term therapy, you have to see the bleeding and ischemic risk. We have to balance. If the patient has a complex intervention such as LMCA disease or something like that, which has high ischemic risk, young patient, we can use prolonged DAPT therapy. There is no harm in it. We can use prolonged DAPT therapy up to 33 months, as in Pegasus TB 54 trial in patients of previous MI. But if the patient is elderly, frail patient with CKD, the bleeding risk is there, we should be we should use shortened DAPT. to balance it.
Yeah, now you have 1 year or even up to 3 months as well.
Yes, 3 months.
That's the benefit. That's the benefit. Especially the DAPT therapy, 1 year generally standard, but we can also use it up to shorten it up to 3 months as well.
3 months.
Yeah, and you know, in
That's
very rare
important, sir,
cases,
because-
long term.
Because within first 3 months, the platelet reactivity is very high. After that, the platelet reactivity is coming down. As I shown in my slide, then the thrombin is gradually coming with the platelet. So after 6 months, you can modulate your therapy. With first 3 months, we have to focus on DAPT therapy, and that is why the triple therapy is kept minimal in first 3 months. Nowadays, triple therapy, warfarin, Noacs with aspirin and clopidogrel are minimized in all guidelines to 7 days, even with the high ischemic risk. So that's the physiology of the guideline.
So thank you. I think if there are now no more questions, because we have very good clarity with regards to all the discussions, primary prevention, selected cases, aspirin, secondary preventions, early triple therapy, short, then combination of DAPT, which can be 3 months to 1 year, then followed by monotherapy, and there is possibility of ticagrelor therapy, selective patients, DAPI or DAPT, prolonged DAPT. Then ACS patients also in similar line, and PAD generally either clopidogrel or aspirin monotherapy, mainly in symptomatic patients or rare cases selective patients. We have rivaroxaban plus aspirin, and with stroke generally clopidogrel has a better outcomes, but in early we can use DAPT again for a very short period of time. So that is basically the gist of your excellent talk. And if we don't have any more questions, we can hand over it back to the organizers. And thank you for an excellent talk once more, and thank you the organizers for giving us this opportunity.
Thank you, sir, for such a wonderful presentation. So before going to the end of this webinar, I would like to announce the next webinar date, which is scheduled on 4th of March. And the topic is anti-mullerian hormone, which is the speaker of that session is Dr. KVS Harikumar from Hyderabad. Oh, thank you, sir. Till then, good night.
Good night.
Thank you.